right now, since it's been 15 minutes. Most people who are here clicking on the Zoom are already here right now.
Ricardo, if you allow me, I would like to introduce Ingrid.
Sure. I'll let Ezio introduce you, since he probably knows you
Ingrid,
more than I do.
Thanks everyone for being here today. It's a big and thanks for this initiative from different scholars from 3 universities in Rio, from 2 universities in Rio, the federal one and the state one, and the Federal University of Espírito Santo, plus the Brazilian initiative for public health, to invite Ingrid Schuurman. Ingrid Schuurman is from South Africa. She is a fantastic colleague. She is a proud member of the WHO STAG, the Technical Advisory Group for the Global TB Program at WHO. And she is running the UCAP, which is the Union Community Advisory Panel, which advises the board of the Union, which is the International Union Against Tuberculosis and Lung Disease. And Ingrid, if I'm not mistaken, is also a board member of the union, right, Ingrid? Yeah, so Ingrid has many hats, and she is a a fantastic advocate in South Africa. Met her many years ago. First time I met her with listening to her personal story, and it's really very touching. And she is very committed to the communities and engagement of communities in policy and advocacy. And coming from South Africa, we can only have the best examples coming from South Africa. So thanks, Ingrid, immensely for your time and for being with us today. Again, sorry for the technicalities that made us start a bit late, but over to you, and thanks again. Cheers.
Obrigado, Ezio. Hola, everyone. It's very nice to join you here today. My name is Ingrid Schuurman, and I'm very happy to talk about making a difference, civil society advocacy for better health. As Ezio mentioned, I'm employed by TB Proof, and we are a TB advocacy organization based in South Africa. So TB Proof aims to end the tuberculosis epidemic by building advocacy capacity, mobilizing resources for TB, reducing stigma, making health facilities safe, and pursuing health equity. So why do I care about TB? In 2012, I worked as a dietitian in the public sector, and I really loved my job. I was working in the Eastern Cape, which is a beautiful province in South Africa, but unfortunately then I suddenly became very sick. So I went to the hospital and they admitted me to the ICU. I wasn't coughing at all, but having a lot of chest pain, and they did a lung biopsy. And initially, the results didn't come back and there was a problem, so it was repeated. And then the lung biopsy came back and they confirmed that I had XDR, or extensively drug-resistant TB. So I was started on TB medication, but the medication has side effects, and I developed grade 3 encephalopathy, and I had complete liver failure. I was in a coma. So my physician phoned my family. To come and say their goodbyes to me, because I was just deteriorating so quickly. But fortunately, after a couple of days, I woke up from the coma. I was completely hypertonic. I had clenched fists. I was unable to read the time, and I was in a lot of pain. I had a nasogastric tube in my nose for feeds and a chest drain. I had an abdominal tap draining fluids. And in that space, I went from being a dietitian treating patients to being the patient, and from being free and then suddenly becoming bedridden. So when I woke up, I couldn't even turn around or press the button to call a nurse for help. And I was in the isolation ward in ICU for over a month. And this experience was very hard for me. I was in hospital a total of 75 days, and I had incredible support. I had a very loving and kind medical team, good clinical care. You can see the nurse there became my friend when I was discharged. The pharmacist drew pictures on medication to cheer me up. But I had a job, I had financial security, I had friends and family, so I had all this in my favor. But to be honest with you, I felt like giving up. It was so overwhelming. And I think that experience, as horrible as it was, and being one of the most difficult things I had to go through, especially the 2 years that I was on the treatment with the injectable drug, in a sense, it was good for me, because finally I realized what suffering comes with TB, and I had all of that in my favor, and I felt like giving up. And the majority of people with TB in South Africa don't even have food to eat, let alone all the other support. And that is why I joined TB Proof, because we are all, just like you, very passionate about person-centered, high-quality care for all people, free from any stigma and discrimination. So I would like to share case studies from South Africa about the impact that advocacy can have. So I hope to share with you about our community health worker TB Champion project, injectable-free drug-resistant TB care, and masks for all amidst COVID. Now, I'm sure you have realized as well, as we saw in South Africa, that health system preparedness to respond to health emergencies like TB and COVID rely heavily upon community health workers or lay health workers, because they are working, they know people in the community and they are trusted. So they also speak the local language, they understand the context. So they are the messengers that we rely on for TB awareness raising. For example, now with South Africa's TB prevalence survey, it was found that the majority of people with TB had no TB symptoms. So how do you educate a community from people from high-risk groups to come and be evaluated for TB testing? You need their buy-in, and that's again one of the roles that community health workers are now playing in South Africa. And they also provide counseling and support, and they reduce TB stigma. However, what we learned through a project that we work closely with community health workers is there's a lack of standardized training across the country. There isn't always effective PPE or protective equipment to protect them from getting sick with TB or COVID, and they have inadequate remuneration. Now, furthermore, when it comes to policy level, there was a policy released for community health workers in 2018. And when we started working with the community health workers in focus groups and workshops, none of them were aware of the policy. So that means a policy was drafted and released without their input or without consultation, despite the policy being for them and having to be directed at their own needs. So please join me now to watch a short video on the role of community health workers and their value in South Africa.
I'm a team leader working with community healthcare workers who are working with TB patients. As I was working with the community, I fell in love with working with patients with TB.
Me wanting to be a community health worker, it's because that I wanted to make difference in our community.
They're starting to understand why are we there and why are we visiting them regularly in their homes. So they appreciate it, and that makes me feel good that I'm actually helping someone getting healthy and living a healthy lifestyle.
We are an NGO, a TB advocacy organization, funded by the Bill and Melinda Gates Foundation for our project, Community Health Worker TB Champions. Healthcare workers were personally affected by TB, and they started the NGO to create awareness about TB and decrease stigma. So we use personal storytelling and we combine it with scientific evidence to advocate for high quality TB care in South Africa and across the world.
This TB story, I started to feel I was sweating sometimes and I was getting tired. So I started to realize that something's wrong about me. So at last I did go by myself. I was having a TB by the time.
We worked with 15 community health workers, and they are managed by an outreach team leader who is an excellent local leader from the community as well, passionate about ending TB.
From the start, I wanted to become a health worker. I followed a career in nursing. And as I was working at the clinic, I saw that there was a problem with TB patients. And today, I'm a team leader working with community healthcare workers, and currently we are advocating for patients on a daily basis.
Their team is also linked to the nursing staff at Kekana Stad Clinic, and they have a good relationship because the nurses give in-service training to community health workers.
I come in to ensure that these patients are linked to the clinics, and once they are on treatment, these patients can get proper support.
All the skills from the community workers, they've got all the leadership skills because they can come with the patient to the clinic. And they have also good communication skills because they were able to convince the patient from the community to come to the clinic when they are sick to request help and for medication.
So community health workers' roles are visiting households, building relationships with patients and establishing trust to educate patients and then link patients with TB symptoms such as coughing or fever to a health facility. So without them, many patients would be missed and not linked to any health care.
I've seen that our community actually needs our help, especially giving service in the houses. For some, they couldn't come to the clinic, especially old people, people with TB and all those things. So I decided, maybe if you can train these people and work with the community, it's going to be fine.
I went to the clinic. I met one of the community health workers. No? So they were asking us the questions. How can they help us? So encouraging us also not to give up and like this. They used to come to us and check. Am I drinking this medication in the right manner or what? So, but I was so happy. I'm happy with the community health workers because they help us. They help me too much. It's not me only, but most of the people here. I'm encouraging them to go to them and seek for help.
Our strategy was to work at local and at national level. So at local level, we engage with these community health workers who are known and trusted and loved by their communities. And we were able to find out what are the barriers to accessing care in Hammanskraal, what could be done so that people can be linked to TB care. And that is where we could learn from them that TB stigma was a main barrier to accessing care. Part of our strategy was for them to come up with solutions, and it was just fantastic to see their innovation because they came up with a theatre play directed by a local television star.
And people were like, wow, really, celebrity in Kikanasta Clinic. That's when they had this attention towards, and they took us seriously. That this community healthcare workers, it's working.
Sometimes you get somebody who's sick and he or she is afraid to talk to people because he or she thinks she'll be labeled by the sickness. So it actually helped us break that stigmatization barrier.
Afterwards, when we did surveys, it showed that stigma was reduced and people felt empathy for their fellow TB patients in the community.
And I enjoyed playing the main role in the play.
TB Proof employed a community health worker, Portia Muedi, and she was key to establish relationships here in Hammanskraal with the 15 community health workers from the Gauteng Department of Health.
My role was to be a link between TB Proof and the CHWs in Hammanskraal. We go to households together with the community health care workers so that I can get to know them. We also made the advocacy letter together so that we can know their priorities. And I handed in the advocacy letter in person to the Minister of Health.
It was encouraging for us to see that after the TB advocacy workshops, community health workers engaged directly with National Department of Health policymakers, and they asked for high-quality standardized training, adequate infection prevention control equipment, and adequate remuneration.
People now see me as somebody who comes with a big impact into their lives, giving health education, referring them to the clinic whenever they have problems.
If they were not there, I don't think I was supposed to go there. They are my sisters. Even my kids, they know them very well. Healthcare workers are here to help us.
From understanding these patients, the process that they go through, from identifying their symptoms to being on treatment, that really touched me. So to date, they are close to my heart.
It brings peace in your life when you know that you wanted to help people and then now I'm actually doing it.
I'm strong now.
After I had TB, it really changed me to my core. It felt like I was stripped away of everything. And after such an experience, I just became aware that and passionate about helping others and the need to increase quality care. And that is why I felt it's so important to get involved as a TB activist, because we need better quality care for everyone, because health is a human right for all.
I'm one of the survivors. I'm healthy now, I'm normal.
And you are a TB champion now.
I'm a champion.
Thank you for watching with us. Oh, sorry. There we go. So I would like for us to now move to the second advocacy example. So from the Community Health Worker Project, we learned that supporting community health workers could enable them to advocate directly with policymakers for their own priorities. So the second example about advocating for injectable-free drug-resistant TB care is a combination of personal storytelling and scientific evidence. And I would like to share a little bit of Pumeza Tesile and Deline von Delft's story with you, so that you can see why TB Proof identified this advocacy priority.
So I thought my life would be high school, university, and then, life. But then TB changed all of that. When I got TB, like normal TB, it was not something taboo for me. But then the problem was when they told me I had MDR and XDR TB. So no, I'm resistant to the first-line drugs. I need to take like 25 tablets a day with an injection every day for like 6 months. And I need to be hospitalized for at least 6 months. You by yourself to protect the society. In quarantine, actually, the injection was painful. Imagine being injected every day for 6 months. And I knew that life will never be the same.
Pumeza Tesile lives in Cape Town, South Africa. She is a survivor of XDR, or extensively drug-resistant TB, and is a fierce TB advocate.
Now with COVID, it's infectious disease, but it got lots of attention compared to TB. TB doesn't choose who you are away from, it just affects anyone. It's airborne, it's in the air, you can just be passing by, you can just breathe in. And then there are side effects. It was very, very hard. I was hospitalized. 4 months later, I woke up, I couldn't hear a thing. They didn't explain that you might be deaf because of taking an injection. So it's very confusing when the doctor comes to you and explains that, and you're like, well, can I get my hearing back? And they say they are sorry, there's nothing that they can do.
Each year, globally, 10 million people get sick with TB, and 1.5 million people die from TB. This enormous disease burden impacts all areas of society.
My first international experience was in Paris, where I just shared my story, and then I asked them what is needed to change when it comes to TB, why the injection is not needed, it destroys life and stuff like that.
Thank you. I will now also share Deline and Arne's story with you.
We thought it was just a dry cough, just sinusitis. We didn't realize that it was MDR TB. I didn't have any other symptoms. There was a time I was waiting for the sensitivity results, and Arne was at work.
I was at work when the pulmonologist phoned me, and the first thing he told me is, I'm sorry, things are looking bad.
When he got home, he wanted to comfort me, and I realized that I've got an infectious disease that's really dangerous.
She had locked me out. I wasn't able to talk to her. There's a glass door, but she wasn't here.
I was very upset, so I was crying a lot. And he wanted to come and give me a hug, but I knew it's just going to be too dangerous, so I locked the door.
This was the worst kind of helplessness. Standing in front of a locked door. Your wife is in tears on the other side. The reason she's locking you out is she's afraid for your safety. The first year, we were just trying to cope, trying to get Deline through the treatment, trying to manage the side effects.
I would get injections in your bum, and because I don't have a big bum, every day I used to put up a drip for myself. The bad thing about this drug is that it causes hearing loss. It causes high-pitched ringing in your ears. Every day when you start putting up the drip, the ringing in your ears starts. So you watch the drip running in, and then you realize, oh my gosh, am I busy losing my hearing? I ended up listening to music the whole day. I don't know, I spent crazy. Because I thought, if you lose your hearing, you can't listen to music anymore. every week I go for audiogram, and it's just getting worse and worse.
I'm sensitive to noise, and she loved music, so before the TV, whenever she'd play music and I had to work, there would be a bit of a conflict. And now the music was on 24/7, but now it was driving me crazy in a different way, because I realized that this music might be the last music that she hears.
They advise that you stay in isolation for 2.5 months, but they don't tell you actually when it's fine to kiss your husband. I mean, you ask them, and you don't sort of. I can remember I thought I don't want to ask the physician, am I allowed to kiss my husband? Because, but it's something that goes through your mind and you really don't know the answer to. So we didn't kiss for 6 months. So it was quite cool the first time when they kissed me, because I didn't expect it, and he just decided he wanted to kiss me, and that was quite special.
You want to kiss her, but you feel guilty and a bit afraid at the same time. But I've been feeling guilty and afraid for so long, and I decided to pack away the guilt and the fear and try and get on with living. We had our first kiss.
You realize how special it is, how special a kiss is, how special it is to sleep next to each other at night.
So we dug deeper, and we were very fortunate to access new research right called Aquila.
I got cured. I got my life back because I had excellent support. And my message for people is that anyone can get TB, and that's why we have to take care of the marginalized. We have to provide proper care for them, and because if we don't, in the end, we will all suffer.
Other people are suffering, we all suffer. In South Africa, there's a very popular saying, Ubuntu, I am because of who we all are. And that feeds back into what tuberculosis is. It's a public health problem. And it's been a roller coaster ride since that first sputum result came back. And we're riding the wave. And we started out very low, with not a lot of hope at times, and we've been very privileged. But now the hope is burning bright, and we want to share that hope and the message that there is life after TB and it can be overcome.
So these two stories of Phumeza and Deline and Arne van Delft was part of the advocacy campaign calling for injectable-free DRTB care. Now, TB Proof co-launched a campaign in 2017 for an all-oral DRTB regimen, and affected drug-resistant TB survivors led a push for national policy change. So Phumeza shared her experience to draw attention to the devastating impact of suboptimal care. And TB Proof also served on the Stop TB Partnership Civil Society panel for the United Nations High-Level Meeting on TB in 2018 to advocate to drop the use of injectable TB medication. Because the political declaration signed by heads of state at that meeting included to commit to global collaboration to ensure shorter and more effective oral regimens for MDR-TB. South Africa and subsequently the WHO did change their guidelines to prioritize the use of bedaquiline and linezolid over injectable drugs. And the change in these guidelines is one of the biggest advances in improving the lives of people affected by DRTB. So we are proud of our advocacy contribution. And a part of that, PUMESA also participated and contributed to the price cut in bedaquiline announced in July 2020, which looks to improve access to all for bedaquiline. The last example I want to share with you was amidst the COVID-19 pandemic. The Masks for All petition was developed as a strategy to decrease widespread community transmission of COVID-19, based on evidence supported by leading infectious diseases and public health experts that cloth masks are effective at reducing the spread of COVID-19. We released firstly a national Masks for All position statement for sign-on, which was supported by 19 organizations and 71 individuals. We shared this with the National Coronavirus Command Council on the 3rd of April and also participated in multiple media engagement. In South Africa on the 9th of April, the government did release recommended guidelines for fabric face mask use, demonstrating advocacy contribution to guideline release. We also engaged with the WHO through a global Masks for All petition signed by 34 organizations and more than 2,600 individuals, which was shared with Dr. Tedros. As I mentioned, TB Proof tries to combine personal storytelling with scientific evidence when we advocate. And here are some scientific contributions from Helene Marie van der Westhuys and Arne van Delft, where they collaborated on an interdisciplinary review of evidence for cloth mask use, used to inform national policy decisions on face masks, as well as global decision making. I hope that through these 3 examples, you feel inspired and encouraged as I am working with partners across the world, and civil society organizations and people affected by TB are impacting policy, and we hope that researchers and medical experts will work closely with civil society to bring change. Happy to answer any questions. Obrigado.
Thank you, Ingrid, for the wonderful talk and for sharing your experience and sharing us with that. The experience you had having TB, it's really great when we have someone share personal and sometimes difficult previous experience. It really helps us understand how patients feel and how all the difficulties that we sometimes don't see or don't acknowledge. Thank you very much for sharing with us that. Does anyone have any questions for Ingrid or want to make any comments? Alguém quer fazer alguma pergunta ou fazer algum comentário? Eu posso traduzir para ela se precisar. People are usually shy in the beginning until someone makes the first question or make the first comment. As you do you have any?
I want people to join up. I speak with Ingrid very often, so so I mean I think that that's an opportunity that people have to talk to her and to learn from this extremely important experience. I think thanks Ingrid for your presentation. I think it is marvelous. I mean the way you guys are putting this forward as an initiative that links personal stories with evidence and advocacy. I think that we have to acknowledge that each country has its context and has its policies and has its functioning. And we definitively are in different paces when it comes to public health in different places. I wish that we could move in a steady and continuous way forward so that we could provide better care for everyone. But I would like to touch on one point, which is access to bedaquiline. South Africa was the first country to implement bedaquiline in large scale for the public. It was like 3 years ago. I think it was 18, huh?
2018, yes. 18,
yes. Believe you or not, Brazil still doesn't have it available. Although because of bureaucracy and technicalities. There is a very slow pace when we come to TB policies in this country, in my country, unfortunately. I would say that all through the world, you know that, like I do, that tuberculosis is an area that, differently from HIV and AIDS, is very top down. It's very based on medical knowledge and the knowledge of care. So what is care? Care is something that you provide, and somebody swallow pills, takes injections, go to the healthcare center, and adhere or not. If he or she has a problem and cannot adhere to treatment, it's his or her failure. It's not a failure from the system. It's not a failure for the treatment which is offered. But I would like to go back to what is policy, because we advocates, we basically work having something in mind, having one objective, which is improvement of health policies. That's our objective. That's what we do. That's what we advocates do and that's what we have been struggling in Brazil. I mean, I started doing social mobilization in tuberculosis back in 2002, when nobody was doing this here or internationally. I remember a talk that I had back in 2004 with Zaki Ahmed from the South African Treatment Action Campaign, who is, for those who don't know, the AIDS world. I mean, Zaki Ahmed is an icon of the international advocacy for HIV and AIDS. And he was making joke of me because I was doing work on TB. And at some point he told me back in 2005, 1 year after that, something like, he was saying like, Ezio, you're now doing work on TB. I said like, yes, because it's important for us. And then 1 year later, he was like saying like, yeah, we missed that train. We should have started working on TB before. And that's the point. TB is the largest killer. It's the largest infectious killer, as COVID will be gone and TB will remain there, worse. TB will be worse when COVID is under control or more or less controlled with vaccination. TB will be worse. So more people, more than 1.4 million people will be dying. Already, WHO in the last report shows that more than that, almost 2 million people died last year from tuberculosis. So it's very serious. And what does it come? So what is the role of advocacy to help implementing new technologies? And when we talk about technologies, I'm not talking only about a machine, a new pill, a new medication, a new compound, a new combination of drugs, this is all, as well as vaccines or diagnostics, these are all hard technology, so-called hard technology, and there is the soft technology. What is soft technology? Is the policy. So is the guidelines, the technical notes, etc. This is soft technology. When we change that, we are changing technologies. And so what do we do, and what was the importance of the South African? What was the role of the South African advocacy advocates to implement bedaquiline in a large scale in South Africa, because South Africa has a how to say, aggressive policy on HIV and AIDS, has a wonderful advocacy down on the ground. Because in Brazil, we are considered not a high burden country for MDR or for XDR. We are a high burden country for tuberculosis sensitive TB, and we are a high burden country for TB and HIV, but not for MDR and XDR. And that's a reason why the bureaucracy doesn't rush up with care, because they think like, oh, there are so little cases. I mean, we can handle that, and we can have extra medication for these people, ignoring the suffering. When I had TB myself, I was in treatment failure for HIV and AIDS, and I was treated also with MDR drugs, and I had injectables. On the 12th day of injectables, I was with Steven Johnson. I was all swollen. I didn't die and I had several neurologic I would say consequences of that treatment. So I know what is being treated for MDR, not as extensively as you did. Thanks God, I could manage that in a shorter time. But people ignore what is the suffering of people living with TB, and I thank you very much for showing these videos and putting a face to the advocacy with TB. But I would like you to say, to develop a little on what was the role of the civil society in South Africa to advocate for the implementation of bedaquiline in a large role. Thank you.
Thanks, Ezio. So I think bureaucracy is something that advocates face often. It's a very relevant point that you are raising here. And something that we've learned from TB in TB Proof is that we need to set collective advocacy goals. So working with partners, and it's often a long term, it takes years, because you need a relationship with the Department of Health and with strategic partnerships. So it's often a result of years and years of work. So for the DRTB treatment, there was a multi-pronged advocacy approach where some of our public health experts contributed to the scientific evidence reviewing pilot projects where bedaquiline was being used. But we were also very fortunate to have Dr. Norbert Njeka as our DRTB program manager. So he was constantly reviewing data, looking at patient outcomes, and advocating himself to give patients in our country the best chance possible to get access to the safer treatment. So it's important to have a national level policymaker who also buys into that. And so at the moment, though, when you spoke about the number of deaths increasing amidst COVID, and TB deaths in South Africa also increased, TB testing has gone down, people are not accessing services, so it is a crisis at the moment. So TB Proof is now focusing again on working with policymakers, because we want our Minister of Health to release the TB response plan. So international guidelines with mitigation strategies to recover from COVID-19 for TB are available. And we are waiting for our national TB response plan, because that will give guidance to community health workers and to health workers on how to fast track, so to catch up, or to at least have a strategy and action items in place so that people can follow those guidelines. And for the past year, that is something that TB Proof has been advocating for. But something that we are actually very happy that we sent an advocacy letter with multiple partners a week ago, or the 29th of October, and the Acting Director General of Health will be meeting with all of our civil society organizations to discuss the release of the TB response plan on the 15th of November. So it also, again, I think the advocacy letter worked because we knew that behind the scenes at Department of Health, there is a draft TB response plan ready. It just needs pressure to be released. I think what is sometimes difficult is when you know that guideline or policy change is required, but it's not being developed yet, so it's not even a priority yet. So it takes hard work to get political attention and buy-in, as you know, Ezio, and I think you have a lot of expertise. And that's why it's so valuable to learn from partners, because it's not like there's one strategy. We use multiple strategies and often have to change because external things or budgets change that you can't control. And that's, I think, what makes TB advocacy so rewarding.
Thank you. Ricardo, any other question?
I have a question for Ingrid. In your experience advocating for TB, I see that you guys do a very good job in mixing personal stories with science to try to be heard and to make change. But sometimes only science have numerous experience, even with COVID, how the denial of science or the denial of what's happening can have a huge impact on how policies are made or the implementation of certain policies. In TB, what was, in your view, what was the greatest obstacle to being heard or to helping implement changes in policies and how people see tuberculosis?
If I'm being honest with you, Ricardo, when I was still a health worker, I also treated people with TB, but I'd never realized how it's actually, you forget it's preventable and it's curable. So I think because TB has been there for such a long time, people have become used to it. If you look at the political attention that COVID is getting, I think a lot of it has to do with who it affects, and with TB in South Africa, you see it affects. We all know it can affect anyone who breathes, right? But it disproportionately affects the most vulnerable communities, and in South Africa, it often affects the Black or the African community the worst. And I think it's an important discussion to have, because it and I'm not an expert on this, but in a sense, you also have to address other issues like structural racism. And I think these conversations need to be had. So it doesn't help to have a national strategic plan that says you want to end poverty and you want to employ people. But if you look at the people who are not employed and the health consequences that they suffer, those discussions are not taking place. And if we're looking at COVID and the attention that it gets, it's affecting everyone, whereas TB is kind of, I think, if the same target groups get COVID who has TB, that it also says something about what still needs to be done so that people care about the local community. And it also goes for me, why did I only become passionate about ending TB when I was affected? So sometimes it takes like a wake-up call, and I think the more people hear personal stories and realize it can happen to them, and it's also airborne like COVID, the more real it becomes to them in their own lives. So yes, I'm sorry for becoming philosophical, but you can't not talk about racism. And I
think you touched on an important aspect of TB, which is it affects disproportionately the more vulnerable people who are usually not heard or not taken care of. Here in Rio de Janeiro, for example, we have the greater concentration of tuberculosis cases are in the slums. or on the Bamboo, where you have a prison. So it's, I agree with you that to tackle the problem with tuberculosis, it's not only a question of technology or getting the drugs, it's of making those vulnerable people heard or seen, or addressing some issues that are usually not only medical or with science. We hear now that, for example, with COVID, the attention that COVID had and the amount of research and money that was spent in these 2 years, we talk about the mental health aspects of COVID or the long-term consequences of the long COVID. And TB, you're just starting to hear that TB doesn't end after you complete treatment, that you have to the follow-up patients to see all the consequences and all the sequelae that TB has, not only on mental health, with stigma, with how to say, side effects of drugs, especially the injectables that you mentioned, and the devastating side effects. I read the stories on the article that you shared with us about people who have hearing loss, and the impact of hearing loss has on people treating TB extensively, like drug-resistant TB. So it adds another layer of complexity to tackling tuberculosis, which makes it harder, for people who are advocating and especially for patients.
And linked to that is, like you mentioned, stigma. And long-term, when we did TB stigma assessments, Goodman, Makanda, and Pumesa Cecilia are working in Khayelitsha, and they spoke to people who were caregivers of someone who had TB 10 years ago. And they said it's the first time someone asked them about the experience, and they were crying and saying they still don't get invited to family dinners. They didn't even have TB, they just cared for someone, and they were shut out of families. So I think stigma, luckily there's an opportunity with COVID because of the overlap to break down. Even mask wearing now is more acceptable, whereas before if you wore a mask for TB, people would stare. Now it's common practice. So hopefully with the infection prevention control and coughing, people won't be excluded from society or pointed at, but rather it would just be another airborne disease. So let's hope for that opportunity.
Hopefully that TB will be indirectly benefited from these things that we're seeing with other diseases as well. Does anyone else have any questions or would like to make a comment or share an experience or say anything to Ingrid?
I would like to say that we do have to learn from COVID experience, and TB has been learning from the HIV experience, and we have been, me, like most of the TB advocates, come from the AIDS world, from the AIDS advocacy, and we brought this sense of urgency that does not exist in tuberculosis. The sense of urgency, in HIV and AIDS, we always work it in the sense of urgency. I remember back in early 90s, our lema, how we say in Portuguese, our our quote would be like, who has AIDS is in a hurry. Quem tem AIDS tem pressa. That was our we have to get care, we have to have treatment, we have to have access to support, we have to have free access, etc. So we are in a rush. We have to go against the clock, and this does not exist in tuberculosis. So therefore, I would highlight the two aspects of Ingrid's answer to you, which is the personal level and the political level. On the personal level, I would like to highlight people open the eyes for what she has shown. She has shown the story of two healthcare professionals, herself and Dr. Delph, and about how is to be affected by this treatment and what is to be at the other side of the situation when you are on the treatment. That because people tend to think that what they learn in the medical school or what they learn in general is enough. So I mean, they take out the subjectivities of the patient, of the person affected. We don't like to call people affected as patients. We like to call them as people affected. So when you see the people affected by TB, how that they have subjectivities, and that this has to be considered in all the aspects that you, Ricardo, mentioned, like how now everybody discussed, because everybody knows the mental health effects of COVID in every single person, because this has affected our sociability, our capacities to relate to the other people, and how we function in the society. This has affected us all, and in TB does too, but we have never discussed that, because it, as I said in the beginning, tuberculosis has always been very top down, which means medicals know what to do, patients are patients. That's why we don't like to use the word patient, because we are not patients. We want best treatment, and we want it that now. So the medical knowledge says that I know what is good for you. You swallow that pill, you take that injection, you come here to the clinic every day of the week. Although you don't have what to eat, you don't have money for the bus, you have to come here. I'm sorry, you know. So the medical knowledge knows what is good for the person, but it ignores the person. So and that's what we have to change. And the way the healthcare professionals deal with the TB patient is one obstacle. Another obstacle remains in the policy area, because if we don't change the way we function, how the system provides care, and how treatments are accessible to all people, this is not going to change. I mean, Brazil has the advantage of having the unified health system. Ingrid, I'm not sure if you know that, but the SUS is the unified health system of Brazil, which is a universal system of public health that has contribution for the three levels, the federal, state, and municipal level, and have health units in all areas, and it's free of charge for anyone. So from TB treatment, AIDS treatment, to heart surgery or cancer treatment in the unified health system is free of charge. So people don't pay anything. So in all three levels. But parallel to this, there is a private system. So it's not only it's the public health, which is paid with taxpayers' money, and the parallel private system, which does not offer medication, etc. It's very different. Here in Brazil, it's very different, because differently from other countries, the private system here is not obliged to provide medication for people in treatment, etc., etc. But the public money does. Anyway, what we have to deal is like, how do we overcome the obstacles to that Ingrid so well said, to make policymakers understand that we have to have priorities, that we cannot only Ingrid, I would like to invite you to be with us this Friday between I think it's the same time at 2 p.m. in South Africa, that will have a national meeting that is organized by a community advisory board that I run here in Rio. We'll have a national webinar with the NTP. That will be very good. It's organized by, it's a Simplicity B study here in Brazil, that we organize annually a big webinar. And I invite everyone who is here to be with us between 10 and noon Brasilia time, which will be between 2 and 4 in South Africa or Central European time. to be with us, to be discussing that the implementation of policies. We'll be discussing the new findings. And the NTP, the Brazilian NTP, will be showing the new technical note for MDR treatment. And finally, they will announce that bedaquiline is available. And now it's starting being implemented. But I mean, this lack of urgency for us is not acceptable. I mean, this medication has been approved for the Unified Health System almost 1.5 years ago, and only now is being provided. People don't care if people are taking injections, etc. But we are finally moving to a no oral regimen. But I would like you, I would invite you to come. Although it will be, there will be some sessions in English, but mostly it will be in Portuguese. But there will be synchronized translation into English with our Christopher. So I would like to invite you and all people here in this audience to be with us. I'll send you guys the link that will be on Friday, the 12th, 10 a.m. Brasilia time. Thank you.
Thank you, Ezio, and thank you, Ingrid, for the wonderful talk and for sharing your experiences and sharing your experience with advocacy in South Africa and all over the place. One last chance, if anyone has any questions to Ingrid or to Ezio about TB advocacy or anything related.
People can also feel free to send me an email if they want to. But it was fantastic to be part of the session, and I am excited about everyone's futures as well as global health advocates and making a difference for people who are sick in general.
Yes.
So.
I will add the Portuguese subtitles to the video recording that we have on YouTube, so people who can watch later with the translation in Portuguese, or if anyone wants to watch or tell anyone else to watch on our YouTube channel. It's Centro Brasil Saúde Global, Brazilian Center for Global Health. And thank you again. Thank you, Ezio, for everything. Sorry for the technical difficulties. I'll make sure that next time we have everything ready.
I would like just to acknowledge the presence of two people I like very much. One is Ana Leila. Ana Leila is a great advocate from the metropolitan area of Rio de Janeiro. She is a wonderful TB advocate. She is a member of the Brazilian Community Advisory Board for the Simplicity TB study, and she has been participating. She does a wonderful community grassroots work in the outskirts of Rio. And Juan Spinoza, who is a researcher and a medical doctor in Barcelona, Spain, working with the with the TB Alliance and the EU Pearl Initiative in Europe to have. It's a fantastic initiative to work for universal protocols for developing studies, and I have been working with Juan for the last time. So thank you very much, Juan, for attending. And thanks, Ana Leila, for being with us today. Thank you very much.
Thank you.
Thanks. Bye, everyone. Thanks, Ezio. Thanks for that.
Bye.
Bye-bye.
See you next time. Bye-bye.
Bye-bye.
Luísa, você tá aí, não?
Então, Ricardo, eu fiz uma
eu não sei como é que eu vou salvar aqui o arquivo, né? Se é que consigo gravar, mas gravei no celular enquanto eu traduzia a reunião toda, né?
Maravilha. Eu vou, de qualquer maneira, eu vou ver. A gente gravou no YouTube, né? A gente pode, de repente, colocar 2 versões, né? Sincronizar a gravação. E eu vou colocar uma legenda também no YouTube para as pessoas.
Ok. Tá.
Desculpa,
então,
eu só fiquei sabendo que teria intérprete agora de manhã.
Ok, tudo bem.
Feito o dever de casa direitinho e testado tudo, se estava funcionando ou não.
Tá bom. Ok. Até a próxima, então.
Até a próxima. Um grande abraço.
Outro para vocês.